My name is Russ Derry. I'm the Director of Education at Epilepsy Foundation of Michigan, and this Learn and Share conference call, the topic is entitled Developmental Disabilities and Childhood Epilepsy, and we're very happy to have with us this evening Dr. Iqbal Allarakhia, who is a pediatric epileptologist with St. John Providence Health System. So, Dr. Allarakhia, can you give us a brief overview of your clinical and research interests, and then also your experience with this topic?
I've been practicing for about 20 years after training as a pediatric neurologist and doing general pediatrics before then, and then doing additional training for pediatric epilepsy at the University of Michigan. I worked in Southeast Michigan since then, and for the last about 12 years I've been working at St. John Hospital Medical Center as a staff pediatric neurologist. I see all kinds of neurological illnesses, but my specialty is treating epilepsy, and I do have a very large population with different developmental disabilities, some of whom also have epilepsy. I do teaching. I don't have much research interest besides I was involved with drug studies as a fellow. Published a little bit since then, mostly with the resident physicians for whom I have responsibility of training as well.
Okay. Great. So let's start by defining the term developmental disability. What is a developmental disability, and what are some of the most common developmental disabilities in children?
Well, the most common ones we see are there's a very wide spectrum, but the broad categories which come under developmental disabilities are cognitive impairment, which is a newer term for mental retardation, and this includes individuals whose IQ scores are generally below 70, where the delays are mostly in the cognitive area. The other developmental disabilities are commonly seen are autism spectrum disorders, in which there is not only a delay in both verbal and non-verbal communication, but there is also reduced social responsiveness or interaction, and there is narrow range of interests. Then the other category broad category which comes under developmental disabilities is cerebral palsy, which is more of a motor impairment, where there is impairment of walking or sitting, or if there is increase or decreased tone. There are, of course, other conditions which can be included under developmental disabilities, like learning disabilities, different syndromes like trisomy 21 or Down syndrome or Fragile X syndrome or Rett syndrome. But these are different genetic conditions which can also come under the heading of developmental disabilities.
Okay. So for a definition, basically, would be any disability occurring starting in early childhood. Is that a general definition, or what?
Yeah. Yes. Anything which would affect any area of functioning, whether it's cognitive or social or language or motor function or coordination. And sometimes it may even include children who have emotional difficulties that can sometimes be included as well.
And a term that's sometimes used is developmental delay, that might be used interchangeably. Is there a distinct difference between developmental disability and developmental delay?
No, not much. I think the developmental delay was an older term which is still used. It just broadly means that there is some delay in some areas, so it could have the same meaning as a developmental disability.
Okay. And similarly, another term that is used interchangeably sometimes, but is not exactly the same thing, is intellectual disability, which is, you mentioned cognitive disability, and I think these are both terms that are used to replace the older term of mental retardation. So can you distinguish between intellectual disability and developmental disability?
Generally, intellectual disability refers to cognitive or cognitive functioning, higher executive functioning, like reasoning with memory. So it's more reflects the older definition of mental retardation. It can be interchangeably used with cognitive impairment. While developmental disabilities are the umbrella term which covers different kinds of developmental disabilities with different areas of effect.
Okay. And how does intellectual disability differ from a learning disability or some of the cognitive challenges that might be commonly associated with epilepsy, like memory and attention problems?
Learning disability has a very specific definition, and we use the school definition because that's what is used to provide extra services to an individual affected by learning disability. So by definition, individuals who have a learning disability have normal IQ scores, so they have IQ scores of above 70. But they have lower achievement scores. So individuals who have a learning disability have normal cognitive functioning, except that they are unable to apply their cognitive abilities to actual tasks in learning, for example, math or reading or spelling. So by the school definition, it's usually a person whose achievement scores are about 2 grades behind actual grade level. So if you have a person in 4th grade who functions at the 2nd grade but has a normal IQ, would be defined as having a learning disability.
Okay. And in terms of we've mentioned, I think pretty much all of the conditions we've mentioned before as examples of developmental disabilities. I think all of them increase the risk of epilepsy. Is that the case? And if so, can you provide any statistics on the likelihood of developing epilepsy with different developmental disabilities?
Yeah, so generally speaking, the greater the degree of developmental disability, the more likely a person will have epilepsy. In fact, if you look at epilepsy, is probably the most common coexisting condition in individuals who have developmental disabilities. So if you look at different things which can occur in conjunction with developmental disability, epilepsy is the most common coexisting finding. Now, if you look at the flip numbers, for example, if somebody has a mild cerebral palsy, the risk of epilepsy is probably not increased. But if you look at the more severe forms of cerebral palsy, where there is motor impairment, the risk of epilepsy can be as high as 50% in certain individuals. And if you combine 2 or more developmental disabilities, for example, if you take cognitive impairment and you have cerebral palsy, the risk of lifetime risk of epilepsy may be as high as 50%. If you take autism, for example, there's a wide range in the literature, ranging from about 5 to 40%. So generally, the more severe a person is affected, the more likely the risk of epilepsy. For example, when patients have autism, which is in the high functioning range, the risk of epilepsy may be quite small. On the other hand, if you have an autistic individual who has a higher degree of cognitive impairment, then the risk of epilepsy is much higher. Generally speaking, the cognitive, the higher, the more conditions you have coexisting, the higher the likelihood of having epilepsy.
Right. Okay. Now, a number of childhood epilepsy syndromes are associated with cognitive impairment or intellectual disability. Which of the childhood epilepsy syndromes most often tend to have that as a consequence? The most likely syndrome you would see associated in the literature
and is called Lennox-Gastaut syndrome. Lennox, which is spelled as Lennox, Gastaut, Gastaut syndrome, is generally defined by an individual who has a learning, who has developmental delays, but also has multiple types of seizures, especially tonic seizures, where a person becomes stiff and falls down. But there may be other types of seizures. So that's the most common type of epilepsy which is associated with developmental delays. There are other ones, like, for example, less common syndromes like Dravet syndrome. Dravet is spelled as Dravet syndrome, where children as young as 6 or 8 months will present with initially with seizures with fever, but then start to regress developmentally, and then they have other type of seizures. Another seizure type which can be associated with developmental delays is infantile spasms. Generally speaking, many of these syndromes are called catastrophic epilepsies because they do not only present with seizures, but they present at times with regression. So actually, there is a loss of milestones, or at least there is some delay in milestones. There are other kinds of epilepsies, for example, progressive myoclonic epilepsies, which are very uncommon, but there are several kinds where there is onset of seizures, and as the seizures become more frequent and more difficult to control, there's also a regression not only in intellectual abilities, but with motor function, with gait, with coordination, with language. So these are some of the although not all of the epilepsy syndromes which are associated with intellectual disabilities.
Okay. And for any of these syndromes, is there any variability in terms of the likelihood of having intellectual disability? Are there any cases, like, for instance, with Lennox-Gastaut syndrome, where if treated early or caught early, that you can minimize the risk of intellectual disability, or is it pretty much a foregone conclusion for most of these conditions?
In many of these, the intellectual disability is not improved by treating the seizures, although maybe improved slightly. There are some seizure types, for example, infantile spasms, where prompt treatment can actually avoid intellectual disability in some kids at least. It is generally advised that in some, even if not all, at least in some of these disorders, that prompt treatment does help rescue many of the developmental abilities. So especially with infantile spasms.
Right. And what do we know about causality with these syndromes? Does the epilepsy cause the intellectual disability, or vice versa, or are they both consequences of the same underlying process?
In most cases, they are consequences of the same underlying process. So, there could be, for example, a brain malformation where parts of the brain have not formed, and that may give rise to the intellectual disability, but may also cause seizures. So in most cases, it's the underlying process which gives rise to both issues. But then there are some conditions. For example, there's a condition called Landau-Kleffner syndrome, where onset of seizures can be, which is extremely rare, but can be associated with regression, which loss of language, previously acquired language can be lost. I also mentioned infantile spasms, where the onset of seizures is associated with regression. It's also called West syndrome. So, but in majority of cases, it's the underlying cause which gives rise to both the seizures and the intellectual disability.
Okay. Are there usually structural differences in the brain among children with developmental disabilities, and if so, how do these differences influence the child's seizure and epilepsy type? Are there certain seizure types that are more common in children with epilepsy who don't have developmental disabilities, or is the epilepsy more likely to be focal or generalized if you have a developmental disability?
Yeah, so in most cases of individuals with intellectual disabilities, the brain will structurally look normal on MRI. MRI is the best imaging technique we have, short of being able to go inside the brain and look at it. So MRI or magnetic resonance imaging of the brain gives you fairly accurate pictures, and in majority of cases you'll find normal imaging studies, normal structure of the brain. However, in a small minority of patients, there may be brain malformation. Sometimes these may be very subtle and very difficult to see, and other times may be quite obvious, that the brain may be smaller, or certain parts of the brain may have not developed, or certain parts of the brain may have not migrated to where they should have been. And so you might see in some cases parts of the brain which are not properly formed in a minority of cases. But clearly, the greater the brain malformation, the more likely that the person will have seizures. We know that the seizures arise from the gray matter in the brain. The brain is broadly consists of white and gray matter. There is a gray matter where the seizures generally arise, and when you have intellectual disabilities, the gray matter which is most affected. So the greater the risk, greater the likelihood of brain malformation, the greater the likelihood of seizures. There's a condition I did not mention, which is important. It's a condition called tuberous sclerosis, which is a genetic condition where there are multiple. An individual is born with multiple immature areas of the brain. They're called tubers. And the greater the number of tubers, the greater the likelihood of cognitive impairment, the greater the likelihood of seizures, and the greater the likelihood of developing syndromes like autism. As far as seizure types, one of the hallmarks of individuals with developmental disabilities is that when they have seizures, the seizures tend to be multiple types. So generally speaking, if you have an epilepsy, you generally have one type of seizure with minor variations, but a person with developmental disabilities is more likely to have multiple seizure types. They can have tonic seizures where they become stiff and fall down, or atonic seizures where they lose tone and fall down, or they have a grand mal seizure or a complex partial seizure. And they're also more prone to having prolonged seizures, which we call status epilepticus. So there's a wide variety of seizures they can have. Often, you may have two or more seizure types in one individual. And they can be both focal or what we call multifocal, where there are more than one origin of the seizure, or they can even be generalized as well.
Okay. And to what do you attribute that in most cases? Is it just the injury to the brain, even if it's not structural or obvious structural injury, is just more widespread, and then that's why you're more likely to have multiple seizure types?
Yeah, that's basically it. It's because there's the effect on the brain is widespread, even in absence of any structural change. There's biochemical change, there's a change in the neurotransmitters or the receptors in the brain. For example, with Dravet syndrome, which I mentioned before, there's a mutation in one of the sodium channel subtypes, excuse me, and that predisposes a person to having very difficult to control seizures because they arise from different parts of the brain.
Mm-hmm. Okay. And I think we've already answered this question, but just are children with developmental disabilities and epilepsy more likely to have refractory or intractable epilepsy than children without developmental disabilities?
Yeah, these are children or individuals who who are way more likely to have intractable seizures. If you look at the general population, roughly about 30% will have seizures which are intractable to medical treatment. If you look at individuals who have developmental disabilities, the number can be greater than 50%. So, and when I say intractable, they are more likely to need multiple medications. They are more likely to still have seizures despite being on high doses of multiple medications. And so, yes, they are much more likely to have intractable seizures than individuals without developmental disabilities. And it may be because of they have multifocal disease, or they have, and it makes treatment of those seizures much more challenging.
Right. So, are there other epilepsy-related risks that are increased by having a developmental disability? You mentioned status epilepticus. Can you talk a little bit more about that? Also, SUDEP, is there an increased risk of that as well, or other risks that I haven't mentioned?
The risk of SUDEP is vastly increased. SUDEP is a sudden unexpected death in epilepsy, and I don't have the exact numbers with me, but it's in the order of being tenfold of the general population or more. So it's the risk of epilepsy is clearly increased. One of the factors which increases the risk of sudden unexpected death in epilepsy is the seizure not being controlled, or needing big doses of multiple medications to control seizures. So those are some of the risk factors. Plus, individuals who have developmental disabilities are more likely to have other medical issues, for example, difficulty with swallowing, they may have reflux, they may not be able to stand or walk, which may increase the risk of seizure, choking or aspirating, or the risk of injury is much more increased. They're more likely to have complications from seizures as compared to the unaffected population. For example, they may be more likely to have pneumonia, more likely to get injured, more likely to have more prolonged seizures. So they're also at a very high risk of developing complications from the seizure. And sometimes these may be from the high doses of medication we may have to administer. These are patients who, when they come in with prolonged seizures, are more likely to need respiratory support to help them breathe. They're more likely to have kidney problems, more likely to have muscle breakdown. So there are a whole host of medical conditions which can accompany individuals who have prolonged seizures.
Right. Related to that, a subset of people with developmental disabilities may have to use wheelchairs. Are there specific first aid guidelines for tonic-clonic seizures in people who use wheelchairs?
I guess they have to be, taken out of a wheelchair if they start to have a seizure, and you have to ensure that they are not in any harm's way, that there are no sharp objects might hurt or compromise a person. Clearly, if you are wearing seat belts, sometimes that can or the devices, the assistive devices, adaptive equipment which is attached to the wheelchair may constitute a risk for someone who is having a seizure. So clearly you have to get the person out of the wheelchair when they're having a seizure and have them on the ground, so it's much safer. You want to make sure that the individual doesn't get hurt from the equipment around him or her.
Okay. So is the epilepsy treatment approach for children with developmental disabilities essentially the same as it is for children without, or are there specific differences that are, related to developmental disability and not just simply related to the fact that the seizures tend to be more difficult to control?
I mean, there are challenges because the seizures are medically intractable. You often have to resort to using more than one medication, and when you use more than one medication, one of the challenges may be that there may be more side effects. And the other issue is when you use more than one medication, the medications can interfere with each other in terms of the availability of the medication to control the seizures in the body. So there may be interactions which may diminish the effectiveness, or there may be interactions which may increase the side effects. We know, for example, that if you use more than 2 or 3 medications, you are more likely for the medication to cause cognitive side effects. There may be certain challenges which may be unique to individuals with developmental disabilities. For example, individuals with developmental disabilities may not be able to swallow tablets, may not be able to, take liquid, certain dosage forms. It may be hard to give. And when you give medications as a liquid form, it may be a very large amount you have to give. Sometimes, so those are some issues which can come up, which are unique which are very unique to. There may be other medications which may affect the availability of the medication. So they may be taking antacids or medications for treating spasticity or medications to regulate mood or behavior or even attention, which may interact with the medication. The other things may be that the metabolic rate may be high, so it may be that they may need larger doses of medication to have the same effect. So those are, and certain side effects may be higher in individuals with developmental disabilities. For example, the cognitive effects may be more pronounced, or the effect on bone loss. For example, if you're using an enzyme-inducing drug, such as dilantin or phenobarb or primidone, the rate of the likelihood of vitamin D turnover may be much higher, and there may be higher likelihood of having osteoporosis in the long term. Yeah, so there are issues which are more unique to developmental disabilities. Now some you always try for a single drug if you can, because a single drug is more effective and it has fewer side effects and is less expensive and it's easier to administer. But in some cases that may not be possible.
So, given that many people with developmental disabilities are already struggling with cognitive difficulties, which anti-seizure medications tend to have the lowest risk of cognitive side effects, and which are the ones that tend to have the highest? I know all anti-seizure medications have the potential to cause cognitive side effects, but are there those that you tend to gravitate towards and those you tend to avoid due to the likelihood?
Yeah, I mean, generally speaking, some of the newer medications have fewer cognitive and sedative effects. A good example of a drug which has very low cognitive side effect is lamotrigine. Another drug which has a lower risk of cognitive or sedative side effect is felbamate, which we don't use as much because of the risk of liver toxicity. Another one which may have a lower risk is zonisamide or levetiracetam or even valproic acid. So these are some of the drugs which may have lower central nervous system side effects, like sedation or cognitive effect or effect on mood or concentration. So it could, a drug could potentially affect all those areas.
Right. Do parents ever consciously choose to put up with maybe a few more seizures in order to have fewer cognitive side effects as a kind of a quality of life decision?
Yes, I think that's very important. Sometimes parents are not aware of that, but many parents are aware of that, and sometimes, the best advocate for a child's well-being is the parent or the caregiver, because, they live with the child and they know what day-to-day issues are. And clearly, if a better seizure control comes at the expense of a person who ends up sleeping all day or is not able to function, then it may be better to allow some seizures to happen, but to have a person who is more alert and more interactive and getting more benefit from interacting with the environment. So it's a very delicate balance which you have to take in place. Having complete seizure freedom may not be possible unless, if you do, it may be at the expense of significantly making the person very sleepy or not able to function or being very irritable or not even being able to walk. So I think you have to look at the overall quality of life. The quality of life may include maybe a good quality of life may actually be more improved if with being alert and more interactive, and having a few short seizures a day, in contrast to having somebody who has better seizure control but ends up sleeping for most of the day.
Right. So, beyond seizure control, are there any unique benefits of the ketogenic diet and vagus nerve stimulation among children with epilepsy and developmental disabilities?
Yeah, I think the biggest benefit with the ketogenic diet and the VNS is that, those are not drugs, so they don't have any cognitive effects. There is suggestion that VNS may actually make people slightly more alert and may have effect of improving the mood as a side benefit. So I think that the main unique benefit of the ketogenic diet and the vagus nerve stimulator is that there's a lower risk of cognitive effects. And not only that, many times by using one of these ways of treating seizures, you're able to reduce the dose of medications the patient is taking. So you even have a secondary benefit of having to take fewer drugs and therefore being more alert. One of the advantages of the vagus nerve stimulator or the VNS is that the compliance is 100% because the device is there and you're not dependent on somebody administering a medication to you. The VNS is always there and it fires at a predictable rate. So increased compliance is another benefit with the vagus nerve stimulator. So yes, there are unique benefits. There are certain rare conditions which actually can be treated with ketogenic diet. For example, certain mitochondrial disorders, or there are rare glucose transporter defects which may respond very well to the ketogenic diet. So there may be some additional benefit from treating specific metabolic defects in certain very few individuals who have seizures and developmental disabilities.
And have there been any studies looking at whether either of these treatments actually affects interictal epileptiform discharges and whether that would have any benefit on cognitive function? Have there been any studies looking at EEGs and whether EEGs improve as a result of these treatments? Not only ictal EEGs, but interictal EEGs.
Yeah, I'm aware of some information in the VNS as cause-induced interictal activity. I'm sure there may be studies also showing that the ketogenic diet can reduce the interictal activity. So, short of having seizures, if you look at the spike waves on EEG, people generally accept that the greater the number of spikes you have, the more likely a person is going to be affected. but I'm not aware of any specific studies. Not that there wouldn't be any out there, but I'm personally not aware of any study which links ketogenic diet to the frequency of interictal activity.
Okay. How often is surgery an option for children with epilepsy and developmental disability? And when it is an option, what types of surgery are most likely to be used?
Well, there are different kinds of epilepsy surgery. The most common type is resective surgery, where area of the focus of seizure, or where the seizures arise from, can be surgically removed, provided it does not come from an eloquent area of the brain. An eloquent area may be area dealing with language or reasoning or memory or movement or vision. All kinds of epilepsy surgery are actually suitable for individuals with developmental disabilities, depending on the type of seizures they have. Even if a person with developmental disabilities had two or more areas where the seizures are coming from, if one area can be identified as being the most active, a person, if you're able to reduce the seizures from 10 a day to maybe 1 a day or 1 or 2 seizures a week, it may be worthwhile doing that surgery. Then there is a subtype of patients whose one hemisphere or the one side of the brain is involved. For example, in a patient who has inflammation of the brain called Rasmussen's encephalitis, or if they have a condition called Sturge-Weber syndrome, where there's an abnormality of blood vessel which affects mostly the whole one side of the brain. In such individuals, a hemispherectomy, where most of the cerebral hemisphere from one side is removed, often with very good seizure control. And then there's another epilepsy surgery type which is used which can be quite effective for certain seizure types, such as drop seizures or atonic seizures. It's called corpus callosotomy, where the fibers, the nerve fibers which help the two sides of the brain to communicate, is called corpus callosum, in the midline of the brain can be partially divided or cut, and that can sometimes give you very good seizure control. So yes, there are. So individuals with developmental disabilities can still be very good surgery candidates. In fact, the surgery may be more effective than ketogenic diet or VNS in many individuals with very good outcomes at times. Sometimes you may be able to achieve seizure freedom, but at the very least you would expect to have significantly reduced seizure number throughout the day.
Okay, great. So because some children with developmental disabilities have communication difficulties, that can create challenges in tracking and managing both seizures and side effects. So, for example, the details of a simple partial seizure may be difficult to communicate, or subtle or internally experienced medication side effects the person may not be able to communicate that. So how do parents work with children to manage epilepsy despite communication challenges?
Well, most parents have good intuition about the children, and they're able to tell when a person is having a seizure and when they are not having a seizure. However, at times, determining some behaviors, like, for example, tremors or head nods or jitteriness or sleepiness or irritability may be mistakenly labeled as a seizure by the parent. So sometimes, even though as good parents are in being the best in knowing their children, sometimes they may be mistaken and they may overcall seizures, or on the flip side, they may under-recognize seizures. And sometimes you may have to resort to doing a continuous EEG monitoring to actually accurately determine what movements and what activities or what behaviors you see in an individual are, whether they are seizures or not. Individuals with developmental disabilities are more likely to experience movements or tics or tremors or repetitive behaviors such as head nodding, which may be mistaken for seizures, or daydreaming or zoning out, or daydreaming, which may be mistakenly labeled as seizures. So there are different things you can see in individuals who have developmental disabilities, which can be mistaken for seizures. And so sometimes you have to resort to monitoring, doing EEG monitoring to differentiate behaviors. Clearly the more impaired an individual is, the more difficult it will be for the parent to determine whether a behavior they are saying, is it because of maybe the person is getting too much medication, or are they still having seizures? Are some seizures subclinical where they don't show any movement? So it can be quite difficult at times, even for parents.
Right.
And even worse for the care providers who do not know the individual very well. Right. And the same thing may apply to medication side effects, because for example, the sleep-wake cycle may be very disrupted in an individual with developmental disabilities, and at times the parent may think that the child is excessively sleepy, but at other times the child may be completely alert. So I think every individual is unique, and they will have their own challenges, which sometimes is difficult to figure out. Sometimes physical therapists or speech therapists or teachers or aides may be able to give more information. So sometimes collecting information from everybody may be useful in order to determine what the exact seizure frequency might be.
Right. In your experience, do families of children with developmental disabilities sometimes miss out on opportunities to improve quality of life because they view seizures more as a symptom of the child's developmental disability rather than a separate condition that warrants its own management? And do you think if they, looked at epilepsy as its own condition rather than seizures just being a symptom, they might be able to open doors to new treatment and management options?
Yeah, I think it's important for parents and caregivers to periodically reassess and see what their goals are. And there may be new treatments out there, new medications out there. There may be new treatment approaches out there. There may be new improvement to the diet. For example, the ketogenic diet. Some individuals have done very well on modified Atkins diet, which is much easier to administer, or the low glycemic index diet. So I think it's generally parents and caregivers do a very good job of being advocates for the children, but I think it's also important for them to take time out and step back and look at the whole picture rather than focusing on just the seizures. You want to maximize the quality of life, which means the patient can go to school, can do activities which can be possible. For example, learning vocational skills, for example. So I think it's important for parents and caregivers to step back and then look at the whole picture from time to time, so that they do not miss out such opportunities to get improvement in the care of the children.
Mm-hmm. Right. So for children who have epilepsy and developmental disabilities, under what circumstances is it better to see two or more neurology subspecialists as opposed to seeing one neurologist who can treat both the epilepsy and the developmental disability?
I think if if the epileptologist or the person who's treating the seizures does not have experience or interest in treating other issues, for example, changes in mood or behavior or attention or alertness, then it may be better for that person to be seen by more than one person. So it depends on the interest and comfort level of that person who's treating the seizures. If they feel comfortable in treating or looking for other issues which may occur in addition to the seizures, for example, is a person able to concentrate in school? Is a person alert and awake? Is a person able to walk? So there may be cases where a patient may also need to be seen by a physiatrist or a developmental pediatrician or a psychologist or a neurologist who's more interested in managing the other coexisting conditions. So I think it's unique to every person. The needs are unique to every person, so they have to determine the need based on that individual.
Right. So what are some of the key steps to in your experience, to maximizing success in school for children with epilepsy and developmental disabilities?
I think the most important thing is to work for parents to work closely with the teachers in maximizing their abilities. So and also making accommodations for the disability. So, for example, somebody is not able to walk and uses a wheelchair. You want to maximize the ability to be mobile. If somebody is not able to concentrate, then you want to maximize the ability to concentrate and do well in school. Through the school district, individuals are entitled to be retested every 2 years at the most. I mean, they may need to be tested every year or even multiple times a year if the needs change. So it's very important to work with the school that the child or the individual gets all the necessary accommodations for them to maximize their abilities. For example, if they have low vision, if they have a hearing impairment, if they have a speech problem, if they have any emotional issues, if they have difficulty getting around with mobility, all those things have to be addressed by the school, and that's by law. So the school has to make allowance and make accommodations for that person to have their maximum ability. So I think it's very important to work with the school. I feel that most schools do quite a good job with such individuals.
Right. Does the how important is the category that the child is placed under? Whether it's otherwise health impaired or SXI, or there's all the different categories. Because I would imagine people with epilepsy and developmental disabilities may fall under multiple categories in special education. How much does that determine success, or is that an important consideration?
I think it's a very important consideration. Generally, individuals are placed in certain category depending on their cognitive or higher functioning. For example, you mentioned other health impairment, which individuals with cerebral palsy may be placed in. Similarly, other categories are autistic impaired, speech and language impaired, cognitively impaired, severely multiply impaired. These are vision impaired, hearing impaired. So these are different categories which look at an individual's greatest disability, which is most likely to affect their ability to function and to succeed. Now, within one category, there may be a wide variation. For example, if an individual is placed in an autistic impaired program, he may be placed among individuals who may be very impaired and not even speak, while there may be individuals who have fairly preserved language. So sometimes it's very hard to get the right fit. And sometimes the parents may have to advocate on their child's behalf and request that the school reconsider so that the child is not placed with very impaired individuals where he will not learn from their peers. He or she will not learn from their peers. So I think the child has to be periodically reevaluated to ensure that they are getting the appropriate services. It's a person with a developmental disability is often a moving target, which means that there's continuous improvement and there may be a need to modify or reconsider what's the most optimal placement in an educational setting.
Okay, and what moving on to adolescence, what are some ways to help teens with epilepsy and developmental disabilities take on additional responsibility for managing their condition, things like taking meds or tracking seizures and side effects or avoiding triggers so that they can maximize their future independence?
Yeah, as much as possible, it's better to prepare such individuals for eventual independence if they are able to. There may be certain individuals who may not be able to be transitioned to more responsibility, but clearly individuals who, for example, have IQ in the range of 50 to 80 or 50 to 70 may be able to take care of their own. Being able to take the medications on time. You may use pill bottles or use alarms to help them, remind them to take the medication. They may be able to better express if they're having any side effects or whether the medication is making them sleepy or not able to function. So I think, it will be better as much as possible, depending on the individual's ability to gradually assign more responsibility to that individual.
So what types of things should be considered when working with a teen or a young adult with epilepsy and a developmental disability to help them figure out what their eventual living situation will be, whether it be a group home or assisted living or having a roommate or living fully independently, staying with parents? There's so many different options. How do parents work with their teen or young adult to try and plan for that?
Generally speaking, if you, I think the older classification of cognitive impairment was somewhat helpful in that regard. For example, if your IQ score was between 50 to 70, you'd be considered as being educably mentally impaired, where you'd be able to learn to, for example, keep some track of money, be able to fix your own sandwich or cook or do things which you can help take care of yourself. On the other hand, a person, and that person, the IQ, for example, between 50 to 70 might need some supervision, but will be responsible for much of the daily needs. On the other hand, if you have an individual who is between the IQ roughly between 30 to 50, maybe almost completely dependent on somebody and may not be able to live on their own, and may need significant supervision. They may be able to do repetitive tasks like cleaning or putting away dishes, but may not be able to do much more than that. So I think it depends on the individual ability. Clearly, the lesser the impairment, the more responsibility can be given. So you could, for example, live in a group home with minimal supervision. On the other hand, a person who is more impaired may need complete supervision for most of the day.
Right. Okay. And what are some key resources that families of children with epilepsy and developmental disabilities should be aware of?
The biggest resource is the school. I think that it's very important for parents to work closely with the school. In the special education services, individual with cognitive impairment or autistic impairment is entitled to getting all kinds of support until about 26 years of age, so well beyond the high school age. So the school is the biggest resource, but then there are other local areas, like Easter Seals and for example, Catholic Youth Services and Big Brother and Big Sister. So there are lots of groups out there, and many times the schools are aware of them. But and clearly the Epilepsy Foundation is another great resource for advocacy and for information. The other resource that parents have to be familiar with is when the child becomes an adult, and if the individual is impaired, they may have to go to court to get the power of attorney to become the legal guardian, so that a parent may still need to make decisions regarding their care and their financial matters. So these are some of the resources you have. But I think the biggest resource is the school and the school system. Sometimes the community mental health in the area may be very useful. There are organizations such as ARC, which may help parents, get paperwork or find out what their rights may be under the law. So I think it's important. Many schools have social workers who can be a very big resource in getting information to the parents about any resources in the community.
Okay. So before we open it up to questions, were there any other issues related to this topic that you'd like to discuss, or?
I think one thing which is important is that individuals with developmental disabilities have multiple medical issues besides the seizures. So it's important to have a very good primary care physician who can oversee their care. There are higher risks of medical problems like reflux or urinary tract infections, constipation, dental problems. So it's very important to have a primary care physician who has an enthusiasm and also has experience in managing the multiple medical issues which may occur in individuals with developmental disabilities. So that's very important to sometimes it may end up being the neurologist who may have an interest and may oversee much of this care. You want to make sure that the person, that the individual gets his flu immunizations and other things to reduce the risk of illness. So I think you need a very good primary care physician to oversee care. Excuse me. How
common is it for neurologists and primary care physicians to actually communicate with each other effectively? Is that kind of the exception rather than the rule, or do I know there's a lot of places claim to be medical homes and have vertically integrated care and all of those kind of buzzwords, but they may still not provide that level of communication between practitioners that you would hope for. Is it just from your sense? Is it more common to have good communication, or is that a little more difficult to find? And if it is hard to get, how do you advocate for that, making sure that your primary care physician and your neurologist are communicating well?
I think it's at the very least the neurologist should send a letter or report each time he sees that individual with seizures to the primary care physician. That's essential. And at least in the Southeast Michigan area, I'm aware of most pediatric and adult neurologists and especially epileptologists send detailed reports back to their primary care physician. I'm aware of, I would say that all epileptologists I know within the Southeast Michigan send reports each time they see a patient to keep the primary care physician updated. Some neurologists may not send in reports regularly, but I'm sure that most of them do.
Okay. All right, so let's open it up for questions. Anyone have any questions for Dr. Allarakhia or comments?
I have a question about head nods. Are those not seizures?
Head nods can be seizures, but most often can be behaviors. They can be called stereotypic movements. It can be a habit. It can be a self-stimulatory movement. For example, individuals who may have visual impairment may sway the head from side to side, or certain autistic individuals may actually have head nods. So in many cases, the head nods may actually not be seizures. Now, if there's a sudden head drop where there's a very slight loss of awareness, that could very easily be an atonic seizure or a drop seizure. So if many times, videotaping this, especially since it's much easier to videotape this at home with the smartphones everyone has. So, but sometimes it's hard to differentiate, routine behaviors or stereotypic behaviors from actual seizures, and sometimes you may need to do prolonged EEG monitoring to determine whether or not a behavior such as head nodding is a seizure or not. But most of the time, head nods may not be seizures.
Okay, well, I can actually feel the jerk in the body at the same time. And if I'm remembering correctly, even though the doctor wasn't sure, it was seen on the EEG. So
yeah. So sometimes it may be difficult to differentiate epileptic versus non-epileptic movements, and you may need to do a prolonged EEG monitoring to be sure.
Okay. Other questions? Okay. All right. I think we will wrap it up a little early then. I had a small group today, but thank you so much, Dr. Allarakhia, for your time and for sharing your expertise with us. And we will the recording of this will be added to the website, so hopefully some more people can benefit by listening to it.
Yeah, thank you very much for inviting me. It was a pleasure, discussing this. It's one of my favorite topics of discussion and interest.
Great. Thanks so much.
Thank you.
Bye, everyone.
Happy New Year.
Happy New Year. Thank you. Bye-bye.
Bye-bye. Bye-bye.